Give it a second until we have full crew. When do we get going here? Okay, so this is a remote download from an adult congenital patient following surgery. And this is a download. Patient has heart block. This is a download done 2 weeks earlier following surgery. So in other words, about a week after surgery, this is what the download looked like. And then this is the download 2 days later that the patient did. And so the question for you is, what are we looking at, and what's the diagnosis, and how should we think about treating this? So I'm going to turn to Dr. Mukhopadhyay, what she thinks.
Good morning, Dr. Pass.
Morning.
Can you go back to the previous one?
Absolutely.
Okay.
So let's just review what these channels are. So we have an electrogram number 1, which in this case they're telling us is A tip to A ring. So that's the atrial lead. And then electrogram 2 is the tip to RV tip to the ring. So this is the ventricular electrogram. The patient actually has 2 ventricular leads, which is why it's saying BV for biventricular pacing. So we have, and this is the marker channel that tells us what the pacemaker is doing. So it's ascents biventricular pace, ascents biventricular pace. And you can see that this is the very nice, clean atrial electrogram and very nice, clean ventricular electrogram. Okay.
okay.
To the next one.
Yeah.
Okay. This is the same patient a few days later.
Okay. So it seems, looking at the A tip to A ring,
Mm-hmm.
uh,
And I'll show you, this is before. This is now.
and the spikes that are present in the A tip to A ring, the one that is present in the first one and the one that's present like 3 beats after that, those also mean ascensing?
Well, the marker channel is telling you what's going on, right? So it's a combination. So AR stands for refractory, atrial event refractory period, and AS is atrial sensing beat. So if a beat is falling within a period that's supposed to be refractory, it will just call it AR. But essentially, every time you see the letter A, it's responding to something in the atrium.
Yeah, so I see that there is an ascens
Mm-hmm.
beat, and then that's followed by the V paced beat. And then there's like a period of atrial refractory period, and then ascens, and then V
I
paced.
mean, look at the impulse instead of looking at the marker channel. What's going on here? What's the atrial rate? So look at this one. What's the atrial rate here?
It's like this one is like around 1, 2, 3, 4, 5, around like 60 beats per minute.
Okay. And
And
what's this one? Is this one
I-
faster or slower?
this is faster. This is
Is it
around
a lot faster or is it just a tiny bit faster?
like pretty fast, I would think.
It's a whole lot faster. What's
Yeah,
the atrial rate? What's the A to A interval in this,
I would say
roughly?
it'll be around like around 300 beats per minute.
Right. So what is it when the atrial is that? And is it a regular rhythm, you think, or an irregular rhythm?
Um, this looks like a regular rhythm.
Yeah, I agree with you. It looks regular. So you have an atrial rate that is about 300 beats per minute. Um, what do you
Mm,
think that is? This is a congenital patient who's had open heart surgery.
Um, I would say like, is it like some kind of a flutter?
Yes, this is some kind of flutter, or sometimes we would call this an intraatrial reentrant tachycardia because to denote that it is a flutter in somebody who has incisions in the atrium. So presumably this is some kind of atrial flutter around an incision or multiple incisions in the patient's heart. Um, so okay, so you've made this diagnosis. So now what are you going to so the patient is at home
Hmm.
and does not actually feel this. They have complete heart block. So, right,
Hmm.
because look at the ventricular rate. What's the
Right.
ventricular rate here?
It's like 2, 3, 4, 5, around like uh, 60 beats per minute.
Right, it's a little slower than 60
Yeah.
beats per minute. And so when this is an important lesson, which is that when somebody has a normal ventricular rate, but their atrial rate is fast, sometimes they are unaware that they're in atrial flutter. So sometimes the only time that people feel flutter is when their ventricular rate accelerates. In other words, when they have more conduction through the AV nodes. So you should always be wary when you meet a patient for the first time who's in atrial flutter. Sometimes they'll say to you, I just felt it this morning. I think it started this morning. But I'm telling you that despite the fact that this patient's atrium is going at 300 beats per minute, they had no idea that they were actually in this arrhythmia. Okay, so you're going to tell them to stay home, come in. What do you want to do with this patient?
I will ask them to come in.
Okay, so they come in and you interrogate the device, and in fact, this is what you see. Same thing that you're looking at. So what do you want to
And
what
do
do you
we
want to
do
do?
we know how long this patient has been in this rhythm?
It's a good question, and actually, the memory of the device suggests that it probably is less than 2 days, probably more like one day, because um, 2 days earlier there was a normal tracing. So
So
probably about 24 hours.
so because it's around 24 hours, I will be concerned about whether there's like whether there's any thrombus or not. So I would do a TE to rule out a thrombus.
But generally speaking, again, 24 hours is the line in the sand. So we think it may be a little under 24 hours. So somewhere in the range of 24 hours. The other thing is for atrial flutter, although again, the risk is higher, it's not as big a concern as atrial fib. In other words, generally speaking, if someone's at about 24 hours, but it's been flutter and not fib, we would be a little less concerned. Also, the patient was on aspirin, which is not a great anticoagulant, but it isn't nothing. So we decided that we were going to treat this patient as if they were less than 24 hours. So is there anything you could do in the office to try and fix this problem, or what do you want to do? What would you do for the patient? So now you're going on the assumption that this is just under 24 hours. What do you want to do?
I would go ahead and do DC cardioversion.
Okay, so that's reasonable. Is there anything else you could do to try to would you
Uh,
put this patient on an anticoagulant?
like you said that it's like less than 24 hours
It
and
is, but this is the first time the patient's ever had it, and the patient has no idea that they're in it.
um I would then put them on an anticoagulant
Yeah, why?
because I want to prevent the formation of a thrombus.
Right. I mean, I think that's a fair statement of all human beings. We would rather that they not have a thrombus, but why in this patient would you do that?
Um,
I mean, you could argue that it's the first episode the patient's ever had. They've never had it before. If we cardiovert the patient, we won't have atrial flutter anymore. But why would why in this such a patient, why would you still want to think about putting them on something?
is it because like I would be concerned that this might happen again, so decreasing
Right.
chances of thrombus formation if it happens again?
Certainly that would be the reason you would anticoagulate anybody, but why in this patient, right? I mean, if we knew the patient was never going to have it again, there'd be no reason to anticoagulate. So yes, we're worried they're going to have it, but why would this asymptomatic patient be a patient of concern for you? Well, it's because they're asymptomatic, right? I
Yeah.
mean, so there are some people who have atrial arrhythmias who can tell you on the dime exactly when they went into it. And then there are other patients who have no idea. This patient, unfortunately, has no idea. And so I think the concern is that because the patient can't tell that they're in it, um, I would be worried that they could have further episodes that are unrecognized. And unless the patient does a download, we won't know remotely. Just happened randomly that the patient did a download, but they might not have. So you said you could DC cardiovert. I agree with that statement, but is there anything you could try in the office other than DC cardioverting to try and terminate this, or any other mechanism to stop this arrhythmia?
We can try like because she has a pacemaker, we can try like rapid pacing on the pacemaker to see
Rapid atrial or ventricular pacing?
uh rapid atrial pacing.
Right, right. So generally speaking, that's exactly right. You could atrially pace, and you could try rapid atrial pacing to see if you could pace terminate the tachycardia. Now, that's not something you'd want to do in the clinic if somebody had AV conduction, because the rapid pacing could cause either rapid conduction or it could cause degeneration of the arrhythmia into atrial fibrillation, in which case the ventricular response rate may be much faster. Or so you don't really want to do rapid atrial pacing in the office in someone who has conduction in general, because you don't know what you're going to end up with, particularly when you have to pace. How fast would you have to pace this atrium to try and get them out, Katoki, do you think?
Um,
The
I would
atrial rate is about 300 now.
so maybe like 310 to 320.
Yeah, you'd have to pace very fast, maybe even faster. And when it's this fast, by the way, the chances of being successful are lower, because when you have to pace a lot faster than this, the atrium may not capture it much faster than this. This may be about almost as fast as the atrium can go. Um, in other words, if you pace at 320, you may not even capture it because it's going to be refractory at that fast of a rate. So in this case, I actually did try to atrially pace this patient out multiple times. And on a few occasions, I was able to induce atrial fibrillation for 4 to 6 beats, but it immediately went back into this rhythm. I tried about 18 or 20 times and paced as fast as 350 to 380 beats per minute, even. And again, the only reason I felt it was safe was because she has complete heart block. And so I knew that the ventricular rate throughout all of this was going to still be about 60. And so this was, unfortunately, we were unable to pace terminate this. So, okay, so if you take this patient to the cath lab, how much, how are you going to set up the defibrillator?
Like I'm going to sync it. It's going to be a
Sync
DC.
to the A or the V?
Sync to the V.
That's correct. That's my favorite trick question. There's no way to sync a defibrillator to the A, and we wouldn't want to anyway, because the concern is putting an R on a T wave, of course. Right, so you'd sync to the V, and how much energy would you give the patient?
I would give like around 1 joules per kilos.
Yeah, you give about half to 1 joule per kilo. And let's say it failed, what would you then give?
I can go up to like 2 joules per kilos.
Yeah, you can give 2 joule per kilo. And in fact, that's what worked in this patient. 1 joule per kilo was not successful, but 2 joules per kilo were. And okay, and what kind of anticoagulation would you use for this, Katoki? The patient's out of it, they're in the recovery room, they're feeling good. Of course, they felt fine before. What would you do for AC in this patient?
Like I could give like a direct thrombin inhibitors like apixaban.
Yeah, you could do something like that, which is what we did. You could start warfarin if you're old school. You could give Lovenox if you're an evil person and want to inject needles into them. There's many different options. What you wouldn't do though is give aspirin alone as a protective, choice. But yeah, so that's sort of the so this demonstrates, I think, nicely the benefits of remote monitoring. This was actually just picked up by Jack when he was doing remote monitoring of our patients, which he does every morning. And you know, aside from putting them in a nice into electronic folder that's protected for me to review, he's also reviewing them, and he astutely noticed this in this patient and informed me, and that's how we got going in managing the patient. Any questions about this?
Thank you.
Okay, thank you. Good job. All righty. Uh, Here we are in a post-op patient who has heart block, and the heart rate is 140. And we're looking at this tracing, and you're asked to comment on this because there seems to be something wrong here. So why don't we ask Dr. Capon what she thinks is going on here. She's going to be in attending soon. We're not going to have this opportunity anymore.
Good morning. So looking at the tally, so it looks like we see A pace, B pacing based off these spikes here in the first, let's say, third of the strip. And then as you move forward, you lose the spikes. But I think, at least from looking at my computer, I still am able to elicit a P wave and then a QRS.
I will say again, the patient has complete heart block.
Okay. Yeah, but to me, I don't see any kind of hemodynamic changes either. I think we just lose the pacing spikes.
Okay, why is that? I agree with all of those statements.
Yeah, I think someone may just have turned off the pacing spike option on the actual monitor, but it still looks like we're A pace, B pacing.
Right. So again, basically you're right, but you're wrong. So you're right. The pacing spikes seem to go away, and yet the heart rate, right, stays pretty much exactly the same. The blood pressure remains exactly the same. And basically, this is an example of how the pacemaker modality on the monitor can fail you sometimes. The monitor, you had suggested, Ivana, that the pacing modality was essentially turned off, but it wasn't actually. It's just that the device sometimes has more difficulty sensing the high frequency pacing spikes. So here it's able to see it and it's augmenting it. And here, for whatever reason, it's not. Maybe the patient rolled a little to their left or right, or one of the stickers was less adherent to the skin, but for whatever reason, it didn't see them. And so it stopped essentially amplifying the pacing spikes. And there was concern at the bedside that there was a problem with the pacemaker, but there was not. What it was a problem with this modality on the monitor, which is not sensing the pacing spikes 100% of the time, and therefore causing a change in the monitor appearance. So you should always, I think that you got this completely right you just didn't understand the reason why it was still pacing and the spikes are gone. So it's just an important point, particularly if you're using that modality on the monitor. You always want to look at the EKG itself, and you did it exactly right. You noticed that there was an A and there was a V following every A, and that the rate was exactly the same, and that the QRS morphology is exactly the same. So this was just it's just essentially an artifact of the way in which the ECG is being displayed. Does that make sense? Okay. All right. So why don't we move forward? All right. This patient has a dual chamber pacemaker. The question is everything okay? Why don't we ask Dr. Obsikov what he thinks?
Good morning. Let's see. Do we have an age for this patient?
This patient is 17 years old.
Okay.
17 years and 4 months, 3 days.
Nothing sticks out to me as abnormal quite yet. It looks regular. It looks like it's it's not pacing spikes consistently, but it looks overall like I see a P wave followed by a paced ventricular beat.
Mm-hmm. So this actually is a challenging tracing. Go ahead.
I was gonna say the only thing that is giving me a little bit of pause is the V1. If I look closely, there might be actually more than one P wave per QRS complex, which
Yeah,
makes me think this could be this might have underlying flutter.
you're right. That's exactly right. This is a very tricky tracing, and it sort of highlights how sometimes it can be very difficult to tell. Because I think what you're trying to say is you do see like a P wave, right, before the QRS, P wave before the QRS. So you would sort of imagine that this is working properly. But in fact, if you look in V1, there's like 2 P waves for every QRS. So this is really like a 2-to-1, maybe even a 3-to-1. This is actually an example of atrial flutter with V pacing. And sometimes one of the advantages you have when you're taking care of someone clinically, which I'm not giving you today, is other electrocardiograms of the patient. And sometimes when you pull out an old ECG of the same patient, you realize how profoundly different this is than the patient's usual, electrocardiogram. And that would make this, I think, much more obvious that it's abnormal. So this is a patient who's also in flutter with heart block. So one more here. This is post-op day 9 following a VSD closure. My question to you is, what is the type of block, and what should be the treatment? So why don't we ask Dr. Kalis, the famous presenter at the SCMR, if she's back to give us her opinion on what we're looking at here. I know this is not imaging, but this is our last opportunity to ask you about electrophysiology.
All right. So it looks like the first beat, there's an AH and then there's no V. Second one, there's an AHV. So we have a couple conducted beats and then a couple non-conducted beats.
Where's the block?
And so it's a
And the doctor who wrote this
infrahisian.
was nice enough to tell us that the AH is 50. Did you just say infrahisian? Did I hear that
Yeah,
right? So by that you mean below the level of
below the
mass.
hiss. Yeah.
Yeah, that's correct, right? Because we see that there's an A and an H, so the conduction from the atrium to the His bundle is pretty good, right?
Mm-hmm.
What do you notice about the HV here? So this is a conducted beat, and this is a conducted beat. Any difference between
looks
these?
like it's getting longer.
Right. So this is actually now normally when people wanky block, which is Mobitz type 1 block, we see that the A to H interval gets longer, which is on the ECG displayed as a PR lengthening. But this is an example of infrahisian disease where the HV interval is getting longer, and then we actually have two beats that don't conduct. So is this first degree, second degree, or third degree heart block, Maya?
Second degree heart
And
block.
is this Mobitz 1 or Mobitz 2?
Mobitz 2.
Yeah, this is Mobitz 2 heart block. Where we have AV node is working, but the His-Purkinje system is not. And this is, by the way, the most common type of block we see in postoperative heart block. I mean, when you get heart block after surgery, you get knocked out both in the AV node and the His-Purkinje, but there's always His-Purkinje disease when we see high-grade block following surgery. So your post-op day 9, you have this. So what would your recommendation be, Naya?
We're still, post-op day 9. I know it's kind of later on. I know we say like 8 to 10 is what we wait, but I would think that it's possible that the patient will need a pacemaker, but I'd like to give it at least
I
one
think
more
if
day.
okay, that's fair. But I think if you're taking your boards and someone asks you, the answer is pacemaker.
Okay.
Because we're post-op day 9, and most of the literature suggests that post-op day 9 is pretty much the inflection where the likelihood of it recovering is very low. And certainly if it were to recover on post-op day 10, I would have I'd be very, very suspicious of that conduction, and I would watch it like a hawk that child would have a permanent Zeo patch on their chest monitoring their conduction. But this would be, sometimes in the old days, I think they used to do this. I never have done this, but sometimes I think in the past when a surgeon maybe was certain that they had not knocked off the conduction and they really, really didn't want you to put a pacemaker in because they were sure it was going to come back, they would ask the electrophysiologist to do a brief EP study in order to assess the level of the block. I've never done that. We've always used just the ECG, which is usually very reliable. But so, you could argue that if there had been complete heart block before and now you're seeing this, maybe this is actually a sign of improvement and it would be time to wait. I don't think there's any harm as long as there's temporary wires that work. But the chances of this fully recovering are low, but not zero, but low. So, all right. Any questions about that? Hope that was useful. I think we'll stop here and see you at Sinai in just a little bit. Have a
Thank
good
you.
day, everybody. Be
Thank
well.
you.
Thank you. Bye-bye now.